What happens if the tongue tie is not handled?
They could develop limitation in what we call the phonemes. A child's first phonemes are da, pa, mama, dada, papa. As they age, then the CHs, the THs, the L. So if there's a tongue tie, they're not going to be able to get the tongue up to the roof of their mouth to make the L sound.
By the time they hit 3, their speech is already super affected. They've been talking for like 2 years probably by this point.
Correct. It could be.
Okay.
And this is where the early intervention and special education teams come into play.
We make dental billing and insurance easier to understand. Subscribe to stay updated and help us grow the channel.
And we are back with another episode of Nobody Told Me That. I have a repeat guest, which I love repeat guests because the conversation just flows and flows. Ann-Marie DePalma is here. Ann-Marie, what's shaking?
Everything's going great today. I'm outside of Boston, but it's been kind of cloudy, rainy day today.
Ugh.
Supposedly the sun's coming out and summer will be here in a couple of days. So
Yeah.
hopefully we're going to be warming up soon. So how's your day going?
Well, yesterday I was very, very disgustingly hot and sweaty because I was out in the full sun at Virginia Beach. And so I thought I was looking forward to the sun. And then I realized I am not. And people think Boston is always cool and chilly, but you guys get muggy and hot when summer hits. So we're just in for it. Okay, so weather talk aside, the reason why Ann-Marie is on again is she's always doing something new and fun. And so she's been speaking for a very long time. Her and we spoke together years and years ago. That's how we met. And so the variety of topics that you've been able to talk on has always been super impressive. And last time you and I chatted, you were like, yeah, I've got a whole bunch of other stuff I'm teaching on. I'm like, what on earth? So you have, and it comes from your clinical background, but also because you're a pretty smart cookie and you can pick up on things and you have a good way of communicating it. So you're talking about women's health, you're talking about AI, TMJ, and there was another one, developmental delays, which honestly is a big topic and nothing I've ever tackled on this. So I really want to get your take on pretty much all of those topics. So from a front office point of view, how can we best prepare? Let's just start with AI, because I know that's what you came on last time. Last episode you came on, you gave us the rundown on AI and radiographs and all of that. And it was super fun to talk about. But you're also talking about AI in the admin space, AI all over the office. So do you think enough people even know, or people are still discovering it, right?
Right. And there's that negativity to it as well. We bring AI into the office. What about my job? What's going to happen?
Yeah.
So a lot of the admin side of the practice is a little apprehensive about it. The same with the clinical side. They don't understand the full potential that it could bring into the practice. Again, there's a lot of walls. And when I present my program on AI, what I do is I break down those walls. I say, okay, this is what AI is. This is where it came from. How can we use it in medicine and then now in dentistry? And it's going to be that link that eventually brings us back to medicine. It's going to be that medical dental integration that we always keep talking about, but we haven't fully embraced.
Well, we haven't really had a way to even marry the two unless it was electronic health records talking to each other. But now that we can compress it, summarize it, quickly gather the information, I do think we're a lot closer to it.
Exactly.
Than before. When you say pushback from the admin team, dude, I feel that, because that's what everybody's worried about is, first of all, the outsourcing. Everybody wants to outsource my job. And I'm like, well, but you got other things to do. And then they're like, well, but AI is going to replace that. I'm like, somebody's got to handle the AI. Do you remember, Ann-Marie, when email was not a part of our day?
Right. I remember,
yeah,
in the days of early dial-up, that noise,
right.
See how far we've come, and that's one of the things that I talk about in terms of the AI. Look at where we were years ago. Computers were housed in big rooms that had to be cooled down. Now today, everybody has a computer in their pocket,
For sure.
So change is something that always happens. And we have to be part of that change. And when we're not, we're left behind, whether that's an individual or whether that's a practice. If you don't embrace change, then you're going to be way behind everyone else.
Yeah, and I hope that somebody listening isn't saying, well, I'm tired of being told, that I need to do this and I need to do that. So I think more of like and I get it. Like when people are saying you've got to get with the times, I'm like, no, I don't. Like my initial, no, I don't. But I do feel that as managers, we have to be so flexible and understanding that just because we don't want to do it doesn't mean everybody else on the team may not want to do it. So there's a whole integrations piece, which your whole career has been nothing but helping teams integrate new stuff. Like that's all you've done. And
Exactly.
so change management, how do we handle that as a manager? How do we handle bringing in this new technology that people are like, ugh, how do we do that?
Well, one of the things that I talk about in the programs, whatever program I'm doing, is involving the team right from the get-go,
Mm-hmm.
putting out those objections. Whenever we have change, our inner 2-year-old comes out. I don't want to do A, B, C, or D,
Yeah,
whatever.
yeah, yeah.
But we have to find out the reason why. What's the objection? Just like when you're talking to patients and presenting a treatment plan, what are their objections? They may say, oh, I don't have time, or I can't do it because of blah, blah, blah. But what's the real reason? Is it truly time, or is it money, or is it fear? What are
Mm-hmm.
those things that are causing the objections, whether it's for a patient or for a team member? Get it out in the open. Be part of the solution.
Yeah, and it is very interesting to have conversations with the people who have to do the change because a lot of times it's something they didn't ask for, but now it's being dumped on them to do it. And it's almost like another job. Like I can barely keep up with what I'm doing. And if the manager or the doctor is not up on the skills, how are they supposed to convince the team? I see that with AI for radiographs where the doctor understands it enough to buy it, but then he or she is like, well, I got to tell my team why this is so important and I need help with that. So that's a whole conversation there.
Right. Well, coming from a background where I was a software trainer for years,
Mm-hmm.
and as a result, I walked into a lot of offices that made a switch from one software to another, or just started with new software. So it's the importance of training is so important, and making sure that your team is on board regardless of what it is, whether that's a new technology or a new product that you're bringing into the practice for restorative or preventive care,
Mm-hmm.
whatever it is. And one of the things I like to talk about in terms of AI is that it gives us back time.
Yeah.
We're always so time crunched. As a hygienist in clinical practice, I'm being told I have to do blah, 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 blah. But I only have 45 minutes or an hour to do it. And by using technology, using artificial intelligence, it helps give us back some extra time, whether that be in radiographs or voice activated period charting and voice notes and all of that, as well as on the administrative side. For
Mm-hmm.
the admin team, you have the different call metrics
Yeah.
and voice receptionists, those types of things. So there's so much that is now available to help us help our patients. And that's what it's all about, whether technology or anything else, it's about helping our patients.
It's a serious mind shift though, because when you think about it from the patient point of view, what would they prefer? But that's sometimes in direct opposition to what we're comfortable with. So a good example is scheduling online. A lot of people want to schedule online or at least, have a look at what's good for them, like so they could possibly block off time until they hear from you. But we have been so resistant to opening up our appointment books because we're worried somebody's going to stick themselves in there. There's going to be cancellations and all of that. But from the patient point of view, like we make it so hard to be a patient. And I think that was a big change for me is realizing, what, this is better for the patient. We're going to have to figure things out. Like even paying online, like it's better for everybody involved, but to go through the steps of actually programming and getting it activated, it's a lot of stuff that we have to do to make that work. But man, if people want to pay me when I'm sleeping, let's do it. Let's do it.
Exactly. Yeah. And think about, how many times we go to a restaurant now. You don't call up. You go online and you create your time. I just
Right.
did that earlier today for a restaurant I'm going to over the weekend.
Yeah.
So we have to be able to move with the times and help our patients want the treatment and get the treatment that they need.
So let's go into then the developmental delays part, because I feel like this is something that we need to talk about from an admin point of view. So I'm glad you're going to give us like the clinical skinny and everything, because we're the ones who are hearing the calls and maybe we don't know what the clinicians need, like extra time, extra space. I don't know. Like if someone were to call to me, do I even venture and say, what kind of developmental delays, so walk us through that. Like, first of all, what developmental delays are you talking about, and how are we handling those?
So basically, all of my programs, regardless of whether it's the AI, women's health, or TMJ and developmental delays, all
Mm-hmm.
of these programs have come from experiences that I have had, whether clinically or personally. What happened was when my boys are younger, they are now adults, but when they were younger, they both experienced speech and language and motor delays. And when they were going through all of their therapies, whether it was in early intervention or through special education, all of their therapists were like, "You're dental professionals. Wow, open our eyes to seeing and recognizing early childhood developmental delays."
Okay.
What we know in dentistry is, yes, we're supposed to be seeing a child at age 1. But a lot of offices are still seeing that child first visit at age 3.
Yeah.
But
Yeah.
within that 1 to 3 year age range, there's a lot that's going on within that child that we can recognize and help their parent or caregiver, as well as the child, to not necessarily eliminate, but reduce the frustration. So I talk about various types of speech and language and motor delays that are in really young children. Not so much in the older child. We do touch a little bit on that, but mostly with younger children. What our purview in dentistry is the oral environment.
Mm-hmm.
So speech and language go hand in hand with the oral environment.
Sure.
So as a hygienist, I worked primarily in periodontal practices, but I never saw children. So how would it relate to me? Or how would it relate to an admin team member? That's because even as adults, we may know parents, caregivers, aunts, uncles, grandparents. We may even be one of those. So recognizing what a child may be experiencing in speech and language and in motor skills, and where their delays are expressing themselves, and how we as dental professionals can help refer them to the appropriate sources. We're not going to be treating them, but how do we refer them? And where do they go?
Actually, that's the follow-up question too. Well, there's two follow-up questions. One is when they're young, and when you say, let's say, speech impediment, the pediatric dentist is seeing the formation of the mouth, or is it soft tissue that's not worked? Like, is it a hard tissue or soft tissue spot
A
that they
little bit
can?
of everything.
Okay, so they look and see like range of motion on the child, or if things are misshapen, they can spot that right away,
Right.
right? So, and then who do they send them to
So it
after that?
depends. So, for example, if it's a tongue tie,
Mm-hmm.
they may do laser surgery in their office, or they may
Sure.
refer it out to oral surgeon or a myofunctional therapist, that type of thing. We talk a lot about the differences between early intervention and special education and what those two roles play in helping the child. And when do they fall into perspective? When does a child fall out of early intervention and go into special education? And then what do we do as oral health professionals? How do we code for it? How do we bill for it? How do
Mm-hmm.
we handle dealing with the parent? Especially in terms of, we're looking at a medical history and that child is having some ADD or ADHD symptoms.
Sure.
Is that an example of sleep apnea?
Okay. Okay. So let's put a pin in that for a second, because I want to talk about that. When you identify that there's a tongue tie, what happens if the tongue tie is not handled? Like, what's the consequence of not having that surgery and
So
loosening that
they
up?
could develop limitation in what we call the phonemes. So
Okay,
the
what's that?
phonemes are the sound consonants that we make when we're talking. So a child's first phonemes are da, pa,
Hmm.
mama, dada, papa.
Ah,
And then as they age, then the CHs, the THs, the L. So if there's a tongue tie, they're not going to be able to get the tongue up to the roof of their mouth to
okay.
make the L sound.
So we have been traditional. I mean, and I don't know where it came from, but you're right. Most offices, like at the front, if it's a general dentist office, we basically are like, oh yeah, bring them in when they're 3. And that guidance has changed, but I know that still is out there. By the time they hit 3, you're saying if there was a tongue tie and they have not addressed it, like their speech is already super affected. They've been talking for like 2 years probably by this point.
Correct. It could be,
Okay.
and this is where the early intervention and special education teams come into play. So it's not just dentistry, dealing with the tongue tie. They may be needing speech therapy. But if your state is one where at age 3, the child has to go into special education, then how do you handle that?
Okay.
And who are the therapists that help the child beyond dentistry?
So you mentioned sleep apnea. I have a family member, their child was diagnosed with sleep apnea at like 8 or 9 years old. And we were all like, what? Like kids have sleep apnea. And I guess it makes sense, right? Because they could have tons of soft tissue in their nasal area, or maybe they just, have whatever causes sleep apnea. How common is that? I mean, and how early are you testing for sleep apnea for a child?
So every child born across the United States is eligible to be screened for early intervention.
Okay.
They may or may not qualify for EI, and there's certain criteria that when I do the presentation, I talk a little bit more about. But there's certain criteria that say, okay, this child can receive some services. The family may receive services as well, depending on the criteria. And then once they reach a certain age, whether that be 3 or 5, based off of your state's rules and regulations, they then become part of special education in your local community.
Okay.
So what we do is we talk about what to look for. Why isn't a child communicating well? One of my sons had a lot of ear infections. Another one had seizure disorder. So the medication that they were on created some issues. Now, as a first time parent, I didn't know what to look for.
Sure.
Everything in
Yeah.
terms of pediatrician and the books and all of that were saying, oh, everything's going to be great. He's fine. But it was actually my daycare provider who said, oh, there may be a problem.
Interesting.
So,
Okay.
and then we started looking at other avenues. And in terms of what the program talks about is like I said, I've never worked in a pediatric practice. But for those that do, what to look for in the children that you're seeing. For those that don't, like for example, in my situation in Perio, we very rarely saw children. So, but I dealt with a lot of parents. And when I give this presentation, that's what often comes out. Oh, I know so and so that had, just like you mentioned, there's
Sure.
a family member or I work in a pediatric practice and this would be helpful for me for that. It
Mhm.
covers everyone. It's not just, the pediatric practices, it's the general and specialty practices as well, and all team members. It's not just clinical in terms of what we're talking about.
Sure. So with the sleep apnea with the kids, like are pediatricians screening for that? I mean, that's not necessarily an only oral thing. I mean, are
Well,
pediatric
oftentimes
yeah.
with young children, it's seen as excessive bedwetting
Mm,
beyond age appropriateness,
okay.
the ADHD, ADD
Potential.
diagnosis,
Yeah.
which may actually not be. It
Mhm.
may be that they're not sleeping well,
That's
So in an
yeah.
adult, when we talk about sleep apnea in adults, we talk about 3 episodes a night is considered sleep apnea. In a child, 1 episode, that loss of breath or that excessive snoring. Now, they may also have enlarged tonsils and adenoids that are
Yeah.
contributing to it too. So there's a lot that fall under this. And basically, through this program, what I like to do is just open your eyes, just look,
Mm-hmm.
listen. Oftentimes, the patient or the parent and the caregiver may tell you and help direct you to where you need to go as a dental professional or as, a referral source.
When you are talking about developmental delays, does the neurodiverse patient fall into this? Is that a separate, I mean, I'm sure you
Uh,
can speak on that too, but I mean, is that is that rolled up into there, or is that even like a separate
it's a totally
thing?
separate thing. So at the
Okay.
beginning of the program, I talk about the differences between a delay and a disorder.
Okay.
So a delay is things aren't happening when they should be, like when you should be walking, talking, that type of thing. Where a
Hmm.
disorder is things are developing abnormally. And I don't talk about the disorders per se. I just say
Right.
these are the examples of children that may fall into that.
Well, maybe just because I'm getting a lot of newsletters, I feel like there's just been an increase in conversation about that. And my friend Estella just did a webinar on it, and I was like, oh, I had not thought about a lot of this stuff, right? So
Right.
it's good to know. And yeah, I didn't know like where, kind of make that decision. But as a dentist, that's really when you should get I mean, this everything we're talking about, there should be a lot of communication between the pediatrician. Well, and let me ask you, maybe I'm wrong, or maybe I don't know. Do pediatric dentists have lots of communication with pediatricians in their community, or is it because in medical and dental, a lot of times we're separate?
Exactly. It's
Is that
still that,
community
yeah, it's still separate.
still? You would
Right.
think that that would be where they could really, come together and have good conversations about this kind of stuff. You would think that those two communities would have communicated about stuff. But I don't really find that. The only time I see where the pediatric dentist is integrated is when they do hospital dentistry.
Correct.
But
Yes.
other than that, like there's not some sort of urge to communicate,
No.
right?
No. And
Maybe
a
that
lot
could
of
be something.
times the pediatricians, like I said, in my situation, the pediatrician said, "Oh no, he's a boy. Speech is going to be delayed, or don't worry
Um,
about it." That sort of thing.
okay.
They kind of, I don't want to say poo-poo, but they do poo-poo at times.
I could see that. I mean, especially even from our side of healthcare, if you see something 500 times, you just automatically think that's what it is. Myofunctional therapy is, I feel like it just doesn't get talked about enough. It's fascinating to me. So, for people who are not sure about that, it's really working with the muscles and the formation of the mouth and the development of everything there in order to, kind of avoid big issues later. My best friend is a massage therapist out. She was a former assistant. She worked for us actually. Former assistant, and then went into myofunctional therapy and massage. And this is like a huge part of her practice. Do you feel like, why hasn't it taken off? Do you know why it hasn't
I
gotten
have
a foothold
no
in
idea.
dentistry?
There's a lot of misunderstanding about what it can do and what it can't
Yeah.
do. So I talk a little bit about it in the development, recognizing developmental delays, but I also talk about it in the TMD program, the temporal
Hmm.
mandibular joint program.
Yeah.
So why it hasn't really taken off, I no idea other than the misconceptions
I
about
don't
it.
I don't get it. What are the misconceptions that people think that it's like voodoo science, or it's like you just massage it away? Like that's not what it is. Like what are the other misconceptions out there? Because I have not heard so many of that. So it still is like, what? Why? Why do you not want to talk about it? Like,
Yeah, it's usually a hygiene or an assistant, a hygienist or an assistant who's gone off and taken a curve in their career. So is it some of that negativity for someone doing that?
maybe, yeah, I
Could
guess
be.
so.
It could be not understanding that it doesn't move teeth. It's more of muscles and helping the skull develop and the tissues develop a little bit more normally. So organizations may be pushing against it in
That's a
terms of
shame.
licensing and all of that, which I'm not going to get
Yeah,
into,
let's not get
but
into that. I don't want angry emails about anything. So,
right.
but I will say that when she was giving me kind of the skinny on like when a baby, if the baby doesn't have that sucking muscle, like that impacts everything from here on out. And then the formation of the maxilla, like all of that. And it just the way she talked about, first of all, she was so excited about it because it just made sense. And then the more she talked to me about it, I was like, why isn't everyone doing this? And I just don't see it, Ann-Marie. It's so sad. But TMJ is where she sees the most. That's where she sees people. Like the doctor that she works with, the dentist she works with, firmly believes in massage helping with TMD. So let's get into that. So, first of all, what is TMD and how are we helping people with that? Because, man, it sucks.
So temporomandibular disorders, the disorders that affect the head and neck and the muscles of mastication, as well as the joint itself. So I have one of the course titles I have is TMJ, TMD, what's it all about? When we
Mm.
talk about the joint, we're talking about the TMJ, temporomandibular joint. When we talk about TMD, temporomandibular disorders, it's the disorders of whether that be just muscle, whether that be joint, or whether that be a combination of joint and muscle problems.
Okay.
So again, this comes from my experiences. I, a number of years ago, developed TMD.
Mm.
And as a result, I was working for a periodontist at the time who did some TMD treatment. He started treating me because one day I just couldn't open. I was locked. So he gave me appliances, had me see physical therapy, had me do a number of different things, couldn't help, sent me to someone else after a number of months. They did very similar types of things. And then at that point, they ended up saying, you need surgery. So I
Wow.
ended up having surgery done. And at the time, they were removing the disc. So when we talk about the joint itself, we
Mm-hmm.
have two bones, the temporal bone of the skull and the mandible.
The mandible that
And
moves back and forth just for the
right,
people.
up and
And
down, the
and
lower
also
jaw.
for people who are newer to dentistry and heard her say mastication, that's chewing. So don't it's not a freaky word. It's just that just means chewing. I just want to make sure like new people are getting the full scope of
Good
it. But go ahead.
catch.
Yep.
Yes. The
Go ahead.
muscles of chewing, or the chewing muscles. So
Hmm.
we've got the temporal bone of the skull, we've got the mandible or the lower jaw, and in between the two is a disc.
Okay.
And just think about the knee. How many times have we heard of athletes having meniscal problems? They have to have
Right.
surgery. So
Okay.
it's basically the same type of thing. That disc gets out of place. And that's what happened in my situation. The
Okay.
surgeon repaired it, but over time it perforated. So they eventually had to take out the disc.
Okay.
Now, fast forward in all sorts of ways. As a hygienist, I wanted to know what was going on. And when I was going through all of it, I was either finding things that were either way above me, I couldn't understand. I'm pretty smart, but there were things I couldn't understand.
Right.
And then it was either way below me. So, as a hygienist, if I was having difficulty, what about the average patient?
For sure.
So that's when I started educating patients and team members, whether that be admin or clinical, about TMJ and TMD and how we as dental professionals can help the patient understand what's going on. Some of the treatments that are out there are great, others are not so great.
Hmm.
So there's a lot of controversy around TMD and treatments. It's almost a wild west, so to speak.
So what is the controversy though that like people think it's not treatable or people think the ways of treating it are like voodoo science? I mean, what is the controversy?
So, a couple of instances. For example, the procedure that I had, which was done a number of years ago, was where they placed silicone into the joint.
Okay.
And over time, the joint is a load bearing joint. So it's putting a lot of pressure on that piece of silicone. All right, in my presentation, I actually have the piece of silicone and you can see the wear mark on it. But if there was a lot of wear, what happens if that silicone leached out into
Right.
the systemic body?
Oh, it's
Because
like when a breast implant is
exactly
punctured,
the
like they have
exact
to get
same
that
thing.
out immediately. It's toxic.
Exactly.
Interesting.
Okay.
Okay.
Recently, that was a number of years ago, but recently there was an appliance promoted by a dentist who said it was going to be curing TMJ. Well, it actually made things a million times worse.
Oh no.
And
Oh,
CBS News actually did a program on it.
oh.
And the FDA is investigating, and there's a lot of legal issues around it.
Yeah, I think I know what you're talking about. Yeah. And unfortunately, when people are in pain, as TMD causes, they jump on things because when you promise you're getting out of pain, like that's why we had the opioid crisis.
Right.
Uh, People in pain are very good consumers. Yeah, go
Yeah.
ahead. Sorry. Go
Yeah.
ahead.
Yeah. If you look at photos of me when I was in the midst of everything, you can literally see it in my face that the amount of pain that I was in.
Yeah.
And there would be days when I would be perfectly fine. I'd be like this. And then there would be other days when I couldn't open. It was
Mm.
like that, and I couldn't eat. Not that I lost any weight, but
How does that not work? I don't get it. But the one thing that I know in offices, the one thing I hear the most when you mention night guard or when you mention jaw pain or grinding and all of that, and grinding is a part of it, right?
true.
It seems like the basic instinct is to just chuck a night guard at people. And it's more than that, right?
Oh, yeah.
Okay. Did you try a night guard initially? Did you try that?
I have had a number of night guards. I've had upper appliances, lower appliances, soft appliances, hard
Oh
appliances.
my
One
God.
appliance was actually an upper and lower linked together.
Wow.
So it all depends on what the patient needs and the practitioner's philosophy. Do they like hard, soft, upper, or lower, that type of thing. But in terms of admin team, dealing with educating the patient, understanding what they're going through. And that's what we
Mhm.
talk about in the program. They're chronic pain patients. So, how do you deal with that? How do you educate them? And then dealing with the insurance process.
Mm, mm, yeah. And a
Okay.
lot of it is being billable is now like if you've got somebody who's documenting well, a lot of that can be billed to medical as long as it's supported and everything. And if they have the right plan, but that's a whole ball of wax there.
Right.
I don't teach that stuff.
Right. Yeah, I talk about you being the dental insurance guru, but
Mm,
then on the other side, the medical insurance. I have a number of people that I refer to. I only know like the very basics.
right, exactly. Yeah, enough to get us in trouble, right? Like
Exactly.
we would be
Yeah.
in so much trouble if we tried to solve it on this podcast. Just not doing it. Is
But I,
the
I refer to the people that know how to handle it.
hmm
So yeah.
So the grinding though is a symptom, but can people just I mean the bruxism, do you see that a lot where it's just people just do grind at night? It's more stress thing. And at what point does it progress to where you would consider having a serious conversation about escalating the care? What point do you do that?
So when there's pain and limited opening,
Okay.
that's
So
when
range of
there's a problem.
motion.
People can grind. We're all under stress lately, especially given our current environment.
Mm-hmm.
We're all clenching and grinding more. But, if it turns into pain or limited opening, you can't open as wide as you once did, or you can't eat your favorite sandwich, without having some pain, that
Yeah.
sort of thing.
Maybe I'm imagining this. Was there a therapy once where you would actually grind away some of the bone so it's not hitting so much? Is that a treatment?
So, in terms of the joint itself, are you
Yeah.
talking about?
Yeah. I feel
Last
like
resort. Surgery is
okay.
last resort.
Okay, because I feel like I read a case study on that and it was part of a lawsuit. And I remember like thinking they can grind your bones down. Like that just sounds awful. So that would be last resort.
Last resort. I have a friend who has had years of TMJ issues and has
Mhm.
had years of treatment to a point where her bones now are totally worn down.
Oh,
Okay.
wow.
So she's actually in New York and went to see someone in New York City, and they recommended complete joint replacement. So basically, or taking out the bones and replacing it with, the way she described it, was a customizable joint.
Wait, taking out the bones, like, but not the whole jaw? Like, is she getting a whole jaw?
No, just the
Okay.
joint
Now you're
itself.
scaring me. I'm like, oh my God, they're taking her jaw. Like, oh,
Yeah.
this is
I don't
wild,
know
Anne-Marie.
all of the ins and outs of it.
Okay, so the joint makes a lot more sense
Yeah.
than just woo. Okay, that would be,
Yeah.
I'd actually watch that surgery. I'd love
I
to see
know. It
something
would
like
be
that.
interesting to see. Yeah.
So, listeners, Anne-Marie and I came up through the International Congress of Oral Implantologists, and we both spoke for the auxiliary section. So, some of the most fun I think I've ever had, and I'm sure you too, is watching the surgery on the main stage that the doctors
Oh,
were, and I'm like, ooh, and sometimes I'd show that in classes because I spoke to the admin people, and I would show like a bloody surgery, and they're just like, oh, and I'm like, are you kidding me? You know, get real
exactly.
here.
So, as a hygienist, my journey started in a general practice,
Hmm.
and eventually I ended up in perio. And in the perio practice, I was doing some hygiene, but most of the day I was assisting the doc in periodontal surgery, removing sutures, and then in implant surgery.
Yeah.
And that's where you and I met, through that.
Hmm.
And I still do programs on implants as
You
well.
do.
So,
Yeah, you
uh,
stay on top. You're like a Renaissance woman. You like know a lot about a lot of things. It's pretty wild. It's cool. But the whole implant world, I mean, when you and I were lecturing on it, like it wasn't abnormal to see an older case of like blades, the blade implants. And if you guys really want to be scared and have never seen blade implants, go ahead and Google it and then,
I
just
actually
be
still have a
thankful.
slide of it in the program.
Do
So,
you really?
yeah,
Are they still being used like those blades? I don't even
I
know.
don't
Like,
even think so. No,
good Lord,
I haven't
no.
seen them in years or heard anything about them in years.
Well, and
But,
that was back when you said implants, like it was a scary thing, and it's because of things like that. Like that's the craziness.
right.
But nowadays it's so common now. Like
Hmm.
I always wondered when we would get to that point where like implants right next to dentures, like patients wouldn't even blink an eye. Because
Right.
when you and I were first talking, well, when I was first talking about you've been doing it already, like people were like, you need to tell me what that is. Like we had to explain what it was.
It's a
So,
screw in your head.
right. Yeah, let me have one of those. Yeah,
My husband has
definitely.
one, and occasionally when he was going through it, I said, "Yeah, you have a screw loose."
Yeah, that's perfect. I love
Hmm.
it. So, when you are talking about women's health, so let's segue into women's health. And if you're a male and not wanting to hear about women's health, I would totally forgive you for turning off the podcast now. But, I hope you stick with it because if you're in the dental office, you are working with a ton of women and you see a lot of women. I wish we weren't so female dominated on the admin side. I mean, hygiene too, but I know with the doctor side, we're seeing a lot more females coming in. But for the most part, on the admin side, it's all females. And when you get a bunch of women working together, there's just a lot of stories that can be told there. But that's not what we're talking about. What we were talking about is having special consideration and looking for issues with women's health has how it manifests itself to us. So talk a little bit about that, but also like why is this such a big deal now? Like is it just more knowledge, more people talking about it, or you
So,
know?
there are a lot of different things. So, basically, in a woman's life, there are three times when hormones really kick in:
Mm,
pregnancy, puberty, and menopause.
right.
So,
And
what I
hopefully it's
talk about,
puberty, then pregnancy,
yeah,
then like hopefully,
puberty,
yeah.
pregnancy,
Let's go chronological order.
in the correct order, or the normal order, as you would say.
Go ahead,
Um,
Emery. I'm sorry.
so, what happens is, at those various times, there are issues that appear that were never there. Now, we know a lot, there are a lot of programs out there that talk about the oral side effects of puberty, pregnancy, and menopause.
Hmm.
I take it from a different perspective. Some of the conditions that we have never heard of, that patients may present themselves with. So, for example, going back to TMJ, did you realize that there are estrogen receptors in the TM joint?
Mm-mm.
So, that's one
So what does
piece.
that mean? So what does that mean for
So,
me?
that means that at those three times, puberty, pregnancy, and menopause, you can have joint symptoms. Or, for example, premenstrually, you can have joint symptoms.
Oh,
So there's a
interesting.
lot of interrelationship. There's a lot of research that has gone on to talk about that. So I talk a little bit about that. I talk about a condition called polymyalgia rheumatica.
I have no idea what that is. What is that?
It's a disease, it's a symptom of an autoimmune disease. So
Oh.
I talk a lot about the autoimmune diseases that kick in during those 3 times that we may or may not have heard of. I initially talk about how important our medical history is.
Hmm.
You know, when we're looking at it from a clinical standpoint as a hygienist or an assistant, or on the admin side, when we're inputting it into our practice management software or scanning it, when we see things that we may not have recognized before, whether that's a condition or whether that's a medication, do we really have enough time to understand what that patient is going through or
Hmm.
what that condition is all about? So, for example, polymyalgia is called PMR. So,
Okay.
what PMR does is it affects the muscles, primarily of the shoulders and the hips. And it's usually seen in women older than 40 or older than 50, sorry, and usually comes on during menopause
Okay.
or other conditions, diabetes type 1. That usually kicks in during these times. Lupus, scleroderma. We've heard
Yeah.
about all of these, some of those, but we don't necessarily understand what they're all about.
So the first one, what is it? PMR? What'd you say?
PMR.
PMR. How does that manifest? Is it painful? Is it irritating? Like what? Like would I know I have something going on?
I didn't.
Oh, okay. All
All
right.
I knew was that I was waking up with pain in the shoulders and hips. Because of my TMJ, I see a physical therapist pretty regularly.
Okay.
So I saw the physical therapist and I would get relief that day or the next day or so. But then after that, the pain would come back.
Mm.
So I went to my primary care for my annual appointment and I said, something isn't right. I want you to do a blood work called C reactive protein,
Hmm.
CRP.
Yeah.
She ran the CRP, which is basically a diagnostic tool for inflammation. It
Hmm.
doesn't tell you where the inflammation is in the body, but it tells you that there's inflammation going on in the body. It was
Well,
elevated.
let me just back up a second. Okay, so yours was elevated, but so C reactive protein, like if you had a heart attack, that's inflammation of the heart. So you would see that. Perio disease, would you see an increase in C reactive? And so I remember listening to a perio, I think it was Rich Nagelberg was
Oh,
speaking, and
yeah.
he said every disease in the body is inflammation of some sort. And I remember that sticking with me that, and then you talked about C-reactive proteins. So I'm like always like I'm looking at that number, and it's interesting. You're talking about yours is elevated. I'm now I have an appointment with a rheumatologist because my number got elevated. And I'm like,
So,
what? So
yeah,
yeah.
so my primary care will wait a couple of weeks, retake it. It was
Okay.
elevated again. She said, I'm going to refer you to a rheumatologist. The rheumatologist took it again. And at this time, it was elevated a third time.
Oh no.
So he suggested one type of possible diagnosis. It didn't work out.
Okay.
But then he suggested this PMR. And the treatment for it is they give you prednisone. And
Ooh.
when they give you prednisone, you get immediate relief.
Yeah,
That's how they know.
but then you blow up because it's a steroid and you're like, so that's how they knew that was the differential. Okay,
Yeah,
got it. Okay, so
yeah.
now you have it. What
So
does
now,
that mean?
so that means I was on a dose of steroid for a number of months, even tried to wean off of it, would have some relapses. And now I'm at a point where the pain is manageable. I know
Mm,
it's there. If I turn over in bed sometimes, I can feel it, or getting up out of a chair. The first step
mm,
sometimes is a little uncomfortable.
okay,
But I'd rather have that than be on the prednisone for a number of different
for
reasons.
sure, for
Okay.
sure. You've probably done a deep dive into this. You're so analytical, but I was listening to a podcast, I think maybe in Huberman or Andrew Huberman or one of those, and one of those healthy people that inspires me to be healthy. And then somehow something happens, right? But I remember hearing that like more people have autoimmune disorders than are estimated. Like it's really high. And at some point, you are going to have one. They estimate that you're going to have at least one. And as a woman, like so many things go wrong in our bodies. So is that something too? Like we need more awareness of just doing that kind of
Right.
testing?
That's why I do this, because it's raising awareness about some of the diseases that we don't necessarily hear about, but also as women in dentistry and treating women in our practice, we see all of these things and we need to educate ourselves and our patients about whatever. So, for example, some of the medications that patients are on for some of these autoimmune diseases cause dry mouth. Xerostomia can
Ah,
cause ulcers, a variety of different things. So, yes, I talk about individuals' conditions, but I also talk about the impact that it has on oral health. So, for example, with PMR, watching your patient getting up out of the reception area or out of your operatory chair,
mm.
how are they moving? That sort of thing.
That's interesting because you wouldn't even think to look for that unless you'd taken a class about it. So
Right. You
I
would
think that's
think it's
wonderful.
arthritic,
Right. Well,
because,
everybody's old. Like I creak when I get up now,
right.
and for you young people listening, it'll happen to you too. So, it happens to all of us. But, now as a healthcare provider, it should be something we at least file away as an observation. It may not mean anything, but it's a good observation to have to refer back to.
And what I do is I talk about ways of products and things that we can use in dentistry to help us assess, looking at the medical history, and then how do we help our patients? For
What are those? What are those products that you're talking about? Like some sort of
like
AI to take a look at
diagnostically,
everything, or okay.
like when we look at their radiographs or when we look at their medical history, what are
Hmm.
they taking? That sort of thing. And then, products, things that we can give our patients for dry mouth, for example. There's a whole bunch of different things that I talk about, as
Okay.
well as things like vertigo.
Oh, so talk about that.
I talk about vertigo.
One of my good
Um,
friends has vertigo, and she's been on medication forever for it, and she doesn't take it. It's not good.
Right. And
So,
patients may cancel appointments because they're having an attack. We think patients cancel appointments because they just don't want to come,
right.
but it could be other reasons. It could
Yeah.
be vertigo or postural hypotension or POTS, postural orthostatic tachycardia syndrome.
Wait, what's that?
So
What's that?
that's something that's really increased since COVID.
Okay.
So it's when you get up from sitting or lying down, your heart rate goes up, but you then get lightheaded at the
So is that
same.
like a long COVID thing? Is that,
It can be, but it not
yeah?
necessarily.
That's interesting. I didn't even think of, I mean, that happens to me sometimes, but I always have to watch, I'm borderline anemic. So I have to watch that. And usually that's an indication for me that it's time to go back, and it's always something. Let me ask you though, because so many of us are actually two things. I'm sorry, Ann-Marie. My mind just goes crazy when I talk to you because you have so much to talk about. The first thing I want to ask is, can you explain, because I just always have to remember that there are people that are new to dentistry that listen to this podcast, because it's a good like this is where you learn. Why is dry mouth a bad thing? Like why is xerostomia an issue that we need to be very careful of?
Primarily because of caries,
Okay.
cavities.
Okay.
Okay. When the saliva is actually considered the new blood, because there's so much information that we can get from our saliva in terms of diagnostics, but also it is preventive. It helps prevent and cleanse our oral environment. So when you don't have a lot of saliva or limited saliva, then you're at risk for a number of different things, primarily cavities or caries.
Because the cavities like that environment, like if they can get right to the tooth and drill in, but if there's saliva, they get washed away.
Correct. Yeah.
Okay. And then for soft tissue, is there a consequence of not having a lot of saliva for soft tissue?
Increase in possible perio disease, periodontal
Ah,
disease,
okay.
and like I mentioned, there are a lot of salivary diagnostics right now that are out on the market, from AI to non-AI types
Mhm.
of diagnostics that are out there that help a patient understand their overall health. And again, this brings us back to that medical integration to a certain point.
Yeah. And that's why people, when we see somebody that's going through radiation treatment,
Mm,
one of the biggest side effects is dry mouth. And a lot of people that don't pay attention to that or aren't told, their oral cavity goes south during radiation treatment because I guess it reduces the amount of saliva
correct. Yeah.
in the mouth.
Yeah, there
So,
was a patient I had when I was practicing that was undergoing chemotherapy for whatever reason. I don't even remember what, but she came to us in her mouth. There was a massive amount of cavities because of the fact that she hadn't been educated on it. And
yeah.
I haven't been able to reconnect with these people, but one of the things that I do is I volunteer at a local hospital.
Okay.
And a
Nice.
couple of months ago, I asked the director of volunteers, what do they do for oral health in the hospital? And they said, oh, yeah, we give inpatients a toothbrush. And I'm like,
Okay. That's nice. Yeah. How nice.
yeah, that doesn't cut it. So they were supposed to speak with the director of nursing, but I haven't had a chance to get back in touch with them to find
Mm.
out exactly what they found out. And, is it possible to, hey, maybe go in and do some sort of nursing education, whether that be for the volunteers or for the nursing teams, that sort
Mhm.
of thing? Yeah.
Yeah. I'm glad you're doing that. That's good. Yeah. So it's really heartbreaking to see. We did have one patient who, and I wasn't even in the back. I remember just hearing about it. I never saw it, but like within 3 months, like it was a totally different mouth. Like,
Yeah.
and it was stunning to my doctor how fast it had deteriorated.
Mm.
But another thing that's kind of surprising is, can you tell us a little, because now we're talking about women's health, hormones, and all that. What is this pregnant gum thing that happens, and how sad is it? I mean, I've seen it. I never had it, thank God, but I remember being terrified I was going to get the pregnancy gums because I was like, yeah, my belly's getting bigger, I've got indigestion, but gosh, I don't want the pregnancy gums, right?
Right.
So can you talk a little bit about that? And yeah,
So
just talk a little.
basically, the hormonal influence causes a lot of inflammation in the gum tissue. So the gums will tend to bleed more easily. But
Mhm.
there is also something, and I can't remember the technical term, but it's pregnancy tumor. Is
Oh,
it,
see.
it's yeah,
Oh,
it's pregnancy gingivitis or pregnancy tumor. I can't remember the
yeah.
exact terminology
I think
for
it
it.
is pregnancy tumor because I remember hearing that, and oh,
Yeah,
yeah, yeah.
that is basically a swelling in a particular area of the woman's mouth. In the perio practice I was in, there was one patient who literally had it. And
Mm,
what we had to do was do a gingivectomy, which is basically cutting the gum tissue. And then the periodontist said it could regrow. She was in the maybe second trimester, if I remember correctly. And
mm,
he said it could regrow in that third trimester. We
mhm.
never saw her again, so I don't think it did.
Thank
But
God,
yeah,
yeah, poor girl.
so there are a
But
couple of
it's
different things that happen. The increase in the inflammation causes the gums to bleed more,
right.
and then
And
this
so if they present
swelling.
though as
Yeah,
seriously puffy,
yeah.
and the hygienists know to look for it, obviously, but when you're an admin team member, like you're like, what? Another thing? And then you learn more about it. But it is something that I don't know. Is it normal to tell people who are trying to conceive or are newly pregnant? Like, shouldn't we be warning them about this? And what is the treatment? There's really no
There really is
treatment.
no
There
treatment
really is
other
no
than
treatment.
maintaining good oral hygiene to help
Okay.
reduce the inflammation as much as possible. You may not
Okay.
be able to eliminate it completely because it's hormonal, but we want to reduce it as much as possible. So
Okay.
maintaining good oral hygiene, coming in for your 3, 4, 6 month maintenance appointments, your recare appointments,
Hmm.
doing everything in terms of home care, brushing. I don't like to use the word floss, but I say interdental cleaning, because
Hmm.
we know patients don't like to floss and they don't
Right.
do it correctly. So I talk
Right.
about interdental cleaning, using things like a water pick or a water irrigator,
Hmm.
using, different types of medications that we can use for our patients. So there's all
I
sorts of different things.
I need I need a microscopic robotic flosser. Like that's whomever invents that, like I'm down. I'll volunteer for it. We have not though talked about the effect on puberty. So say, my little cousin Braylon she's going to be a teenager in a year or two. Like what am I watching out for with her as
So
far as
in
oral cavity?
terms of that, again, or good oral hygiene,
Okay.
we know teens and preteens often don't take care of themselves. And that's
Yes.
putting it mildly. But, trying to maintain as good oral health as possible,
Okay.
brushing, flossing, whatever, and limiting their diet, watching what they're eating in terms of developing decay, all of that. And maintaining hydration too. Hydration, drinking a lot of water.
It's funny. I feel like my son is 25 and I feel like his generation did nothing but drink water. Like he doesn't like the taste of anything else. And now I'm looking like even the younger cousins, like no one's drinking water now. So I don't know if we've swung in the other direction. Like what's going on here?
Right. All
Let
those energy drinks and things like
Yeah,
that are
that's
not
what they
good.
love. Oh, they're
Once in a
terrible.
while, yes,
Yeah.
but
Yeah.
not every day, constantly.
No, and it's not good on your brain either for a young brain to have like all that
Exactly.
caffeine just shot up into you every
Hmm.
time. So let's go back to menopause though. There's a lot of hormones that a woman at that age is either lacking or taking. And I know that they've changed too. Like they used to recommend a whole bunch of hormone replacement therapy, and now they've moved away from that. And now there's a growing market of what we call biosimilar, where they pellets or injections or whatever, it's totally different. It's estrogen and testosterone, right? Like, do we see an imbalance in the mouth? Is that another indicator for
It
us?
can be too. There's something called burning mouth syndrome
Oh, what's
that
that? Oh,
basically is a burning mouth. The patient comes in and their mouth is really irritated, and they're complaining that it's really burning. That's the only way you can describe it. And it's something that happens during and after menopause. All of these things that happen with the conditions that I talk about are things that take over in a woman's health. Like this PMR happens in women over 50.
mm-hmm.
The average age of a woman in the US going through menopause is 52.
Okay.
So 52, 53. So,
Yeah.
all of these things can happen. And in terms of hormone replacement in the program, I talk about there was one study fairly recently that said that women can continue, like you mentioned, that there was, first they had the hormone replacement, then they said taking off of it. And there's been this whole controversy about when to do it, when not to do it. But this one
Mm-hmm.
particular study said that women could actually take hormone replacement into their 80s, but they would have had to have started closer to menopause than later. And if they stop doing it, then they can even restart it again. So it just depends
Wow.
on what the woman and the primary care or gynecologist feel is appropriate for them. Now, this was just one study, but
Mm-hmm.
it still brings out the we don't know type of thing.
Is there a point you think where a dentist will be ordering blood tests themselves? Do you think that's coming to our
I
industry?
think so. Not necessarily blood tests, but saliva tests.
Okay. And so, like something like C-reactive protein, would that show up in a saliva test?
I don't know, but it could.
Okay. It might. Okay,
Yeah.
but at least we know like what bacteria are we have a huge load of in our mouth. Like we would at least know that.
Hmm.
I know some offices will do the diabetic,
Right.
the pinprick test, right? So they'll do that. But yeah, I feel like so much of what we do, I mean, it's all inflammation, right? Oral systemic. Like, why aren't we able to order a blood test?
We should be
Um,
able to. I saw
yeah,
something recently that it was talking about the ability to read the medical chart, okay, and get the latest blood work from
yeah,
that into our practice management software. It's not there yet, but it's
right.
coming.
Right. And I know one doctor I worked with, he was a oral surgeon, but he was very on top of all of this medical dental. He would ask for their latest blood work. And I remember thinking, wow, like I don't even know what I'm looking at. Like I need the chart where it tells you out of range, in range. Like that's how I know. But he's looking at markers and all this kind of stuff and obviously very, has educated himself on that. But I do think we are going to need to work more hand in hand with medical physicians on that because we only have part of the puzzle and they only have part of the puzzle, and it's only when they start talking when they're like, oh yeah, we should probably talk to each other, but they're so siloed. Ann-Marie, when's that going to happen?
I wish it was yesterday, but
Yeah.
the way things work, I don't know.
I
There's this
know.
thing called interoperability where the practice management software talks to the medical software, and it's not doing that yet.
Mhm.
But
Mhm.
there are people in dentistry that are pushing it forward. So
Well,
hopefully,
yeah, I mean, Brian Laskin
yeah,
has been at the forefront of this. I think he's got a program that actually does allow them to talk to each other, but you've got to have dentists that understand how important this is in
right,
order for him to sell his product. I know that's been very frustrating because you know how our industry is. If there's no problem, we don't need to worry about it.
right. We put
And
our
until,
blinders on. We don't need to see it.
yeah.
When I was a software trainer, I would say that offices were surviving in their software. They were not thriving in their software.
Oh,
And
that's
that's
a
the
great way to
same
put it.
thing with what we're seeing with the practices and things like what Brian's doing. They're only surviving. Get me through today. I
Mm-hmm.
don't care about any of this other stuff. Just get me through today.
Yeah. Dentistry is famous for being up to date when it's mandated. When it gets mandated, all of a sudden everybody's going to rush to have. I said, Brian, you're going to be a millionaire in a few years. Like,
Right.
it's not going to happen overnight, which is really, really a shame because it's really the patient. Like you said, it all comes back to, are we doing the best we can by our patient? I think we're doing the best we think we can, but there's always a little bit more.
Are you a dental biller feeling overwhelmed and isolated? I get it. The world of revenue cycle management is complex and ever-changing. That's why I created Dental Revenue Network. Our membership community was created to help you become a better revenue cycle manager and small business operator. Say goodbye to feeling alone and hello to a supportive community of dental billing professionals. Here's what you'll get: monthly billing-focused meetings with peers and experts, business building sessions to elevate your career, resource libraries tailored for billers and billing company owners, introductions to cutting-edge RCM technologies and companies, and a vibrant community for networking and support. Ready to transform your dental billing experience? Visit dentalrevenuenetwork.com today. Don't wait. Join us now and navigate the business of RCM with confidence.
Okay, so I knew we were going to go. I didn't even look at the clock. So we're going to wrap it up, but you are all over the country. You're doing webinars, like how people can go to your website to find out what the heck you're doing. How do they keep up with you?
So they can check me out on LinkedIn, Ann-Marie DePalma, or on my website, depalmaannmarie.com, or email me at depalmaannmarie@gmail. So a couple of different ways you can reach out to me. I do both webinars and in person. I'm leaving tomorrow actually to go do a program in person. So looking forward to that and hopefully seeing everyone somewhere along the way.
Yeah. We always run into each other on the road. We always see if we can grab some dinner or something like that just to catch up. So yeah, definitely look her up if you need somebody to do anything for your study club, for your organization. But you'll do private consultations too,
Oh,
like if a
yes.
team
Yes.
needs it.
Yeah.
So very, very helpful with what you do. So next time you come on, you're going to have a whole bunch of other topics because you don't stop. I mean, that's really what's amazing about you is you find a topic you're passionate about and then you tackle the heck out of it, which is awesome.
Yeah.
So thanks for look, we went over four different topics that you're
Whoa.
knowledgeable on. Like you killed it this time.
Mm-hmm.
So thank you very much for coming on. I'll put everything in the show notes so people can reach you. And dear listeners, as always, I appreciate that you spend your time with me.
And thank you, Teresa, and thank you everyone for listening, and have a great rest of your day.
Absolutely.
If you learned something new today, subscribing is the best way to support the channel and keep learning with us.
We're all super busy, so thank you for making time for me today. The show notes will have any links that we referenced in the episode. You can also find links for my book, events, and my online insurance course, Dental Insurance Design and Management. I speak often around the country on management and insurance issues. Come hang out with me in one of my classes. I promise you'll laugh and learn.